Welcome to Caring Well.
Welcome to Caring Well.
Welcome to Caring Well.
Welcome to Caring Well.
Caring Well. Welcome to Caring Well.
Welcome to Caring Well.
Welcome to Caring Well, a Middleton Pediatrics podcast where we have conversations to help you care well for your child. Today is another one where Dr. Von Edwins and I sit down and talk about a variety of things. We go through some things in depth. We also go through some recent articles, things in the news, and we even respond to some of the questions you've submitted. And first, we're going to introduce you to one of our other team members. So let's go to those conversations. Well, Laura, thanks for joining us.
Yes, thanks for having me.
So we've said at the last time we did this that we wanted to periodically introduce one of our team members to our families. I feel like probably every family we have out there has met you in one form or another.
Some way or another.
Yeah, but not in this form. And so I'm excited. I mean, you've been such a wonderful part of our practice. So how long have you been with us?
9 years.
9 years.
As of January.
Okay. Yeah. And share a little bit about how you came to us, because it wasn't necessarily the typical way.
So I started my senior at UCF. I graduated with a health service administration degree. So I did my internship here for a semester and absolutely loved it. Cleaned some rooms, did some admin work, all the things.
A little bit of everything.
Yeah. And so at the time I was like, if you guys have a job after graduation, give me a call. Great. A month later, got a call and never looked back. So that was a fun, never like officially applied, but just meeting everyone here and the family atmosphere. I just loved the patients and everyone working here is just a big family.
Had we had other UCF interns prior to you?
I think I was the first one.
Okay.
Yeah. So it was one of those, I need this internship to graduate kind of thing. And so luckily it worked out well, but it was a really good period of my time and been here ever since.
So you grew up here.
Yes. Born and raised.
And then went to UCF and majored, you said, in healthcare administration?
Yes.
Yeah. Did I get that right exactly?
Health service administration.
Health service administration. What was it that made you want to do that? When did that come about?
I've always loved the medical field. I think growing up watching Grey's Anatomy, ER, like just intrigued with the healthcare. In high school, I did sports med club and athletic training, so it really sparked my interest and looked at programs at that actually. I actually started as nursing at UCF with a minor in HSA, but I actually loved HSA more. So I switched. So
it was your classes, the administrative classes you were enjoying more than the clinical ones?
Yeah. Which seems odd to switch from clinical to administrative, but I'm a big nerd and love the busy work.
And there are no nerds in clinical.
Right.
So you had to switch, right?
Exactly.
Right. Yeah.
So I switched just to my major for health service and I love it.
Has it been dramatically or even mildly different than what you were expecting?
A little bit of both, I think. I knew administratively just the paperwork side and like phone calls, all of that I love. And then working here, I've actually learned clinical things that I did not learn in college, just triaging little things and responding to parents with the same questions that come through, answering the phone. So, but definitely it's grown myself and my, education and just knowledge of healthcare.
You think you would be different at your job if you didn't know those clinical things?
I think so. I think it gives me not like a one-up, but just to understand the parents too from a patient perspective. And now being a mom, expecting my second child, just that reassurance of...
You're expecting your second child?
I am, surprisingly. Just that reassurance of parents, even if I don't know the answer, just giving them the, hey, let me find the answer for you, ask a question to the nurse. And just being well-rounded, I think I've learned a lot just working here, even answering phones. The voice of the practice. I'm sure people know my voice more than my face.
Yeah. So you bring up an interesting point because partly just by our size and then maybe partly with some intentionality, I'm wondering your motivation as you walk into your office each day that helps you know that I am part of something meaningful and coming alongside families. Because in my mind, that's really easy for someone that's clinically taking care. It's just as true for you. I'm just wondering what's going through your mind when you think about what motivates you towards that.
For me, I think it's just making sure we run smoothly. I deal with a lot of, staff things and putting out fires where they need to be, where patients may not realize that, and just making sure the flow of phone calls are, responsive. The voices and the faces of our practice, everyone is trained to know, the workflow to make sure patients aren't waiting a long time. So I feel like I do a lot of back end stuff that patients obviously don't see the clinical part of it. And just making sure our staff is well-rounded and make sure they have everything they need and answer questions, and all departments kind of the go-to person. So
I think part of the reason that works so well for our families and stuff is what you said before, is that you enjoy it. And that comes through with just interacting on a daily basis, is like you truly do enjoy talking to families and making sure all that's running really well. It's really impressive.
And pediatrics too, it's not always, happy either. There's upset phone calls and things don't go right. So handling those is hard, but someone has to do it. So I definitely like being the voice of our practice and reassuring parents that we've learned from this too when things happen, and parents are understanding of that too, which obviously people don't realize the hardships too, but comes with the job.
So you mentioned having started out in the nursing area and then decided, hey, I really like the administration part of this and stuff. And so something I always wonder with when I talk to people is, what would you be doing now if it wasn't what you're doing?
I get that asked a lot, actually. So I grew up a competitive dancer, so I was always known as the dance teacher, but I feel like I would have probably a school teacher. I just love, like, even here, I'm the Funtivities director, like putting together baskets and coordinating events and just providing that funness to the office. But I think a school teacher of some sort.
Give us a quick little glimpse of life outside of here.
Right now I'm in my mom era. So expecting the second. So when I'm not here, I'm just spending time with my oldest, Colton. He'll be 2 in June. Husband and family time. And we do a lot of science center, splash pads, family. So beach, reading a good book every now and then. But yeah, just spending time with family right now.
And what's Colton? What's he into right now?
Monster trucks, Pixar cars. Yeah.
Like so, he has are you talking about like the real things he wants to?
They're a good size.
Okay, so but not the ones that are at the citrus bowl.
Yeah. I think come next January, he's going to be loving that. So it's been fun.
That's great.
His car face.
What's something about being a parent that surprised you?
For him in this stage, he's slowly talking more, but the babbling and like being a mom, what they're saying, or like the parent, which was like when you hear another kid, they're like, I have no idea what they're saying, but the mom's like knew exactly, which is like a strange thing, but I knew exactly what he was saying or, pointing to or representing. But I think just how much love you have for that child, and the second one coming, and I'm excited for him to be a big brother, to baby girl. But yeah, they just make you grow in a way you never knew.
Well, thank you for the way you are around here. It's great.
Yeah, I love it.
I mean, and again, I think so many of our families have already interacted with you, whether that's phone or portal messages or whatever. But I love that they get to, if they haven't already, put a face with the name. And, thanks for leading us so well.
Yeah, thanks for having me.
We appreciate you.
All right, Dr. Von Edwins, here we are again.
Hey, good to see you.
Yeah, got a lot of different things to talk about.
Yeah.
And so I'm going to let you kind of go whichever direction you want to start with.
But actually, I was thinking about this because I had to walk into my son's room the other day and say, turn down the music, please. And then we see kids come in all the time with these earbuds and stuff like that, is hearing stuff. I feel like we do screenings on kids when they come in for well visits and things. And occasionally we'll get families who come and say, oh, they didn't pass their hearing screen at school. We want to get it rechecked. We want to see what's going on. I thought, man, that's something that we don't talk about very often, just in primary care pediatrics, but it's a big deal. And then it kind of begs the question, well, why do we do them? And what's like the history behind them as well. And so all babies now since the 90s have gotten hearing screens in the nursery. And it's just one of the things that it's one of those, you get your heel prick for your metabolic stuff. You make sure your heart is doing well, and they do a hearing screen on all these babies. And it started back in the 90s when they started realizing that, hey, we're missing a lot of potential hearing loss in kiddos because a lot of times, especially as infants, they don't have any symptoms of them. And there are things that we can do early on to intervene, maybe not to change the course of their hearing in improving it or keeping it from getting worse. But if we intervene early enough, we can help their development in the long run.
Yeah, speech and other things. Actually,
yeah. And what all the research has shown as I was digging through this is not only speech, but this is the main way that one of the main ways that we interact with the world is by hearing it. And so we learn so much by mimicking, and that's where our sounds come from and our speech comes from, but also being able to hear ourselves so that we're
Mm.
able to form words and sounds as they need to be. And kiddos who have even mild to moderate hearing loss, either from an early age or something that's happened as time has gone on, it can have pretty profound impacts on their ability to be successful as they go through life, and especially school and learning and things like that as well.
One of the things that maybe doesn't get mentioned as much is, and it's along the same lines, but social. I mean, you think of elderly and the social isolation that comes with hearing loss. And I mean, all these, going back to your cognitive thing, these studies that say hearing loss accelerates dementia. Not dementia, but I had temporary hearing loss. It's probably been, I don't know, 15 or 18 years ago. And I felt left out of almost everything going on around me socially.
I can't imagine. I mean, we rely so much on it to interact with other human beings and really the world in general. I can't imagine how isolating that feels.
So newborn screen, so it's done. Is that enough?
So if you pass that, you've got a pretty good, the way that test usually works is they're going to play a little sound in the kid's ears, and they're actually watching the brainstem to say, hey, did the brain actually respond to this? And as long as you pass that, you've got a pretty good idea that we're probably in a good spot. Well, then as kids get older, part of what we're doing when we go in to see patients in their well visits and all this is we're trying to assess developmental milestones, most specifically with this communication milestones, personal interaction milestones. And if we start seeing things like speech delays, things like that, we go, could it be that we are having a hearing issue? Could this be based in our ears and not necessarily our ability to form words or the speech parts of our brain? And so although through the first couple months of life and really up until about 4 years old, we are not formally assessing your hearing ability, we're using all these little hints and these constellation of things to say, hey, it's probably working out okay. We're developing well in these places. This is probably coming along with that because we know how important it is for the speech development things. Around 4 years old or so here, we start doing hearing screens at each of the well visits. And because one, it's important, we want to know where they go, especially getting into school. But two, the way that you test these is you have the kids put on headphones and either play a tone or have the recording says, like, point to a slide, and they point to a slide. Well, at 3 years old, if you don't do that well, the question is, well, is it because you can't hear, or is it because you're 3 years old and it's hard to follow the directions of this screener? So around 4 years old, we start doing those at all the well visits to test for those. And if you've got normal ones, then you're great. And then, so that's always an option for screening throughout. And that's what the AAP recommends, is just keep an eye on this as well. A lot of schools will do screenings as well, which is really helpful. Because like I said, sometimes we'll have families come in and say, hey, we didn't pass this at school. And you say, all right, well, let's look in the ears. When you get a mess, little wax, let's get that out of there. Let's do it again. Let's see if there's something else playing a role. And then I think where we stop doing them as frequently, families feel like things are good enough, as getting into like late elementary school, middle school, high school age. And I feel like that's a lot of the places where we start to see some of the risk factors that can lead to long-term hearing damage and hearing loss come up, is loud sounds and just exposure to anything that is too loud. And a lot of times that's the AirPods. It's our earbuds. It's our music in general. It's what the AAP and everything said is anything that's over 85 decibels is for a prolonged period of time has a risk of causing hearing damage that can potentially be permanent. What does that mean? It's like, who knows? So I went looking for things, and that's driving in the car with the windows down is loud enough to be 85 decibels. Having a blender is loud enough to be 85 decibels. Lawnmowers, leaf blowers, all those kinds of things. So things that we come across on a daily basis actually have a little bit of a risk of creating damage to our hearing that we're not necessarily thinking about on a regular basis. And for us, it's one thing, but kids, the way their anatomy is built and having small ear canals and things, there's thought that amplifies the sound, and it could be worse for them. So 85 decibels is the limit for us, but it's probably lower than that for kids.
Yeah. And so you're referring to a sort of a recent policy statement,
Mm-hmm,
the
right.
AAP. And in reading that, they make a big point that you just did as well, that we've probably tended to think of it mostly about intensity. So avoiding, whether that's, fireworks
Concerts,
or
sure.
concerts or excessively loud music. But the point they made too was sort of duration, and that if it's long enough duration, then a lower intensity still can cause damage. And reading it really made me think of, well, two different sort of analogous conditions. One was sun exposure, sunscreen, and skin cancer. That just chronically, even mildly elevated exposures will cause damage over enough time. And pediatrics is all about prevention, and this idea that things that we don't think as traumatically loud sounds might be, if enough. So I think with this policy statement even at least raised a question about sound machines,
right?
and
Even in infancy.
sleeping rooms, right? Yeah.
And one of the things that I found was interesting, and we kind of talked about this with sun exposure as well, is if adults are uncomfortable, if I'm like, hey, this is a little loud for me, it's probably really loud for my kids. It's probably really loud for an infant. And to allow just being cognizant of these things on a regular basis, I think allows you to make more frequent small adjustments to our environments to help prevent these kinds of things as well.
The spirit of a screening test is to do it when you don't suspect something, whether that's a mammogram, a colonoscopy, hearing screening, whatever. The point of it isn't that you suspect something. The point is that you don't. It could be there, and you would want to know if it was.
Yeah, and so many of these hearing issues is, it may be that we can have a child here who has hearing loss, high frequency hearing loss, maybe even low frequency hearing loss, who interacts with us just fine, but that potentially can progress over time or is completely asymptomatic from it because it doesn't really have any other symptoms until it does. And then once again, it's that if you can get in there early, you can potentially play a much bigger role in these kids' lives and help to ensure their development over time.
Shift gears and talk about RSV.
Yeah.
Coming up on it, and that's probably worth mentioning, is kind of what is RSV, what is RSV season? Should as a parent, should I be worried?
RSV, which is what we colloquially everyone refers to as RSV, is this virus that causes an upper and lower respiratory tract infection. Respiratory syncytial virus is what's called. No wonder we call it RSV.
Right.
It's
Much
not
easier.
easy to say. And it is a virus that is ubiquitous in the world. It's everywhere. And it's particularly significant when it comes to infants and babies, especially babies under really 5 months of age, but any baby under a year can be pretty significant illness. Often starts out as just your run-of-the-mill kind of cold symptoms, some cough, some congestion, and becomes frequently a very, very snotty virus. I mean, lots of congestion, thick nasal secretions, and is the most common cause of bronchiolitis, or this inflammation and viral infection of the small airways in the lungs, which can lead to wheezing, respiratory distress. Sometimes kids will stop breathing for short periods of time. Luckily, most of the time, it's not that significant, but other times it can be very serious. And it's actually the most common reason a lower respiratory tract infection from RSV is the most common reason for babies to be readmitted to the hospital after discharge, especially with respiratory distress.
Readmitted after birth?
After birth. Yeah. So they go home from the nursery, out of the hospital now.
Okay.
The most common reason for them to come back to the hospital for any reason.
Yeah. So most common reason, infants, even probably slightly older than that, they get hospitalized with the RSV. So really common. I think I've read 90% of kids will have an RSV infection by age 2.
Right.
But as you just said, most of those will be colds, and then some portion, maybe a third or so, will move. You said it so well, move from an upper respiratory tract infection to a lower. Signs of that are, say it again.
If you're seeing that progression down to the lower respiratory tract, you're going to see more breathing related symptoms. So when it's when it's just this upper respiratory thing, this just rough cold, a lot of nasal congestion, that might get in the way. You're breathing a little bit, but you suction it out of there, things get better. Well, when it gets down into those lower airways, you're going to see more probably rapid breathing. All of a sudden, I've got some blockage. I got to move air a little bit quicker to get the same amount of oxygen in and out of my body. you're potentially going to see babies and kids using more muscles to breathe. So their bellies are really going, they're pulling muscles between their ribs, they're using their neck muscles. Maybe their nostrils are flaring as they're trying to breathe. Really, they're trying to get as much air in and using every part of their body that they can to do that.
Because their oxygen is dropped, right?
Right. Yeah. And they just have all this mucus down there. It's just getting in the way of things. So when you have less space, you got to use it more frequently to get the oxygen in, the CO2 out. And then kids will frequently wheeze with this. So they have that kind of, as they're breathing out, you hear kind of that musical kind of noise. And then if babies are really working hard to breathe, we worry that they can't drink as much and then potential dehydration things. But it really is that respiratory distress, that
Effort,
wheezing and stuff. It's the effort. Yeah. That shows that it's gotten to the lungs.
I've heard people say that, if moving from an upper respiratory tract infection to bronchiolitis, kind of 3 W's, this idea of worsening cough, work of breathing, and wheeze. And kind of, if a parent is trying to know, how do I know if my kid's cold has become, well, ultimately, we want to see you in the office and determine it that way. But those are some of the things. All right. What about treatments for RSV?
So just to touch back on that, a lot of questions that we get from parents as well as we'll say, well, if you see any respiratory distress, let us know. And they go, what do you like? How will I know? And I always talk about all these muscle use, breathing fast and everything. But I really tell parents, I'm like, if you look at your kid and you're like, something's wrong, they look uncomfortable, I want to hear from you right away. Let your gut guide you with that, because you're probably going to be right with that. So you asked about treatment. And unfortunately, because it's a virus, we have to let the immune system do its job. And so it really is typically here in the office, we'll see a kid come in, they've got congestion, they've maybe got a little bit of wheezing, but they're not working really hard to breathe. They look good overall. They're staying hydrated. We may not know that this is RSV. We can say, hey, this is a viral infection. We don't see any sign of a bacterial infection. And as long as we're not getting these worsening signs that we're talking about, it's supportive care. Make sure they're staying hydrated. If they're having fevers, using your antipyretics, your ibuprofens or acetaminophen, and then just supportive care through that and watching for the worsening. That's the most common thing we need to do. There are times where kids do get worse and they start having these worsening symptoms. And whenever respiratory distress comes into the picture, we start worrying about kids not being stable at home. We consider go to the emergency room or be admitted to the hospital. And even when kids are admitted to the hospital or into the emergency room for RSV, it's all supportive care still. Even when I was working in the hospital and we'd admit kids who had RSV bronchiolitis and were having this increased work of breathing, I would tell parents, I'd say, look, it's going to look like we're doing a whole lot of nothing. But what we're doing is we're keeping a close eye to make sure things don't get worse. And so sometimes it would be oxygen on the nose just to help the kids make sure they're getting enough oxygen. Sometimes it's pressurized air in the nose in order to help stimulate their respiratory effort and help make the work of breathing easier for them. So each breath they do take in, they get a little bit more air in there. Even then, we're just supporting them through that. And what really changes it is as their immune system gets in there and finds the virus and gets rid of it, it's their own body that fixes it ultimately and gets rid of it. We're just helping them through that process.
So typical RSV season?
It's interesting because it's different depending on where you are in the country. Ours is usually into the fall through the winter is going to be the most common times to see that.
Yeah, and we, for reasons that are probably not completely understood, we do tend to get it, as you're saying, earlier than other parts of the country. And so really even later part of summer, right? I mean, July and August, we'll kind of see it start picking up. Okay, so running through these things you've said, really common infection, most common reason children get hospitalized, typically a cold, but can progress down into the lungs, which is where it gets more serious. Treatments, there's forever there have been people trying to find treatments and steroids and bronchodilators and all these things, but really nothing other than supportive treatment.
Yeah. And even what, like we said, looks like aggressive support, it's still support at the end of the day.
Yep. And can you get RSV more than once?
Yes, sure can. Yeah. Kind of like you said, the people at the highest risk are going to be infants at the end of the day and young children. If we get RSV, we're probably just getting a cold. And that's one of the things that I think is so worrisome about RSV is we might have a cold and be like, I've just got a little bit of a cold, but I've got a 1-month-old here who all of a sudden it's RSV and it potentially has the risk of really holding more weight.
Which happens all the time with an infant that has an older sibling that has cold, because although you can get it recurrently, generally the only serious is your first time. But that older sibling can keep getting RSV, can get it, and then pass it on to a young infant and more serious.
I think one of the most exciting things about RSV is the fact that in the past couple of years, we've gotten ways to help prevent.
Yeah, do share.
Within the past couple of years, there have been a couple of different options. Specifically, when it comes to babies and infants, there are 2 options to help prevent RSV. One is a vaccine that a mom can get during the 3rd trimester, a couple weeks before they're due. That is a vaccine that induces mom's body to start making antibodies similar to most other vaccines. Then she passes through the placenta to the baby and provides the baby protection for the first, hopefully 5 to 8 months of life, to help, one, prevent getting RSV potentially in the first place. But even if we do, the chances of it being a severe case is much, much lower with that.
So mom can get vaccinated late in pregnancy and give some borrowed antibodies to the baby that they can use during this most vulnerable time.
Correct. Yeah. Because that's really the goal, is let's protect while we're very vulnerable. The other option is moms who either don't get that or can't get that. Once the baby is out in the world, we can actually give them, once again, borrowed immunity. And so you'll hear people talk about it's a vaccine for RSV. Technically speaking, that's correct. If you really want to dig into it, instead of inducing an immune response like we're doing for mom, where she's going to make her own antibodies and hand them off, as many other vaccines do, even for kids, with this, what we're actually giving is we're giving the kids the antibodies that have been made for this and saying, here, you're going to be protected immediately because your body doesn't need to make these. We'll just give them to you. And you will then be protected with this borrowed immunity that throughout this first RSV season that you're alive, once again, with the hopes that you either don't get it, or if you do, it's going to be a significantly more mild case of RSV. The reason we say it's borrowed is because we are just giving the antibodies rather than teaching our own immune system how to use it. Those will go away eventually, but they're gone by the time the risk is significantly lower of getting a severe infection.
Yeah. So again, being a little bit semantic, but if a vaccine is something that stimulates one's immune system to produce protection, a vaccine is an immunization because it helps produce immunity. But this is an immunization that's really not a vaccine. You're getting protection, but not because your own immune system has been stimulated. You're just getting antibodies given to you.
Correct. And at some point, you will likely be exposed to RSV again. And then your body will create its own protection by making its own
antibodies. But you're
antibodies.
out of the vulnerable window.
But you're not as high of a risk of something serious happening at that point. Yeah.
And so, but you can't do both.
Correct. Yeah. If a mom gets the vaccine while she's pregnant, the baby does not qualify for it. Our guidelines say if it's unsure whether or not mom got it, we should give it as well. But it's correct. You don't need both. It's one or the other.
And currently, it's just for the first few months of life.
So you can't be any older than 8 months old to get it unless in very specific circumstances.
Unless someone's higher risk.
Correct. Yeah. And it's within the first RSV season that you're alive. So less than 8 months, first time we go through RSV season, that's when you qualify to have it.
Yeah. And so you said you led with this topic of the RSV protection with what's exciting. Even that's an understatement. I mean, it has been longed for because RSV has been such a terror for so long. And there have been multiple attempts to develop vaccines that just haven't been able to be as good as needed. And so the last 2 years have really been something that everybody's been excited about. And have those results been realized?
It's pretty incredible what's happened. So there was an article that came out in Contemporary Pediatrics recently that said, so we've had this now for a couple of RSV seasons, so we can actually get big number data and really see what's happening. And it said that the reduction in the number of cases of RSV across the board just being diagnosed was reduced by about 80%. And then the reduction of, even with those kids, of becoming severely ill, like being hospitalized or even put into the ICU, were also reduced by more than 80%, which is just fantastic. I mean, it's impressive. It really
And that's
is.
consistent with what we've seen in our office. Not that
Mhm.
we're not representative of everywhere, but
Right.
it's definitely what we've seen is a dramatically decreased number of illnesses. Okay, let's run through some articles, some things that have been in the news, and just tell me how interested or not you are. Feel free to say I'm not that interested. There have been some articles recently just about infant food contaminants, and so products being pulled from shelves. Some of this has been concerns about arsenic levels and rice, but then the more recent one was infant foods with elevated iron levels. How interested are you
Iron levels
in the public's
or lead
the
levels?
green white lead? You're right.
Yeah.
Lead. Sorry. Yeah.
So yeah, right. There's recently an article that came out that showed that there was a voluntary recall of a lot of pouches, like baby food and kid pouches, that showed increased levels of lead.
Yeah. Iron might have been a good thing if we had extra iron in there. Lead. Yeah.
I find it interesting for a couple of reasons. One is a couple of years ago, I think it was 2023, there were some lead poisonings. There were some kids who got sick because there were increased levels of lead found in foods. These things matter. And so the reasons this really interests me is, one, it's important because that's a big deal. Because if you really do get lead poisoning, it can have mostly developmental and neurological effects for the rest of your life potentially.
Right.
The other reason it matters for me is it makes me really glad that there's people out there who are like, hey, I caught this. And what's really nice with this recall was they found lead levels that were, so the FDA says, hey, if you've got 10 parts per billion, which basically means, and I asked ChatGPT to like make that reasonable for me. What does that mean? And it basically said 10 parts per billion was if you took an ink dropper that drops out a half of a milliliter of ink and put that 10 drops of those into an Olympic-sized swimming pool, that's 10 parts per billion. That's what the FDA says is, hey, this is the upper limit of what's acceptable for any food out there. They found for lead specifically for lead, they found in these pouches 13 or 14 parts per billion. So only a little bit more. Important nonetheless, because ideally 0 is where we want to be, but only a little bit more than what it had been. Back in 2023, these levels were 2,000 times what they were supposed to be. There were things of like 22,000 parts per billion or 20,000 parts per billion in those, what caused those issues before. So the risk this time is lower, but man, am I glad somebody's out there looking for this. And I'm glad that they're finding these things. It's a good thing that they found this.
Yeah. People are monitoring. And to be clear, no one's been reported sick from this one. And there's been a voluntary recall of all this. Yeah, it feels to me that the lead one, I think, I find more interesting. Some of, same thing you're saying, that there are people monitoring, and because really this should not be in food, period. A lot of these other things, they're in soil, they're going to be at varying levels. Right. And so it's alarming when you hear of arsenic in your rice, but that is something that probably will be there, and it needs to be regulated and monitored. And I'm not saying it doesn't, but lead levels can be checked. And so if someone said, as a parent, what do I do about this? Certainly if there were concerns, and there's other sources of lead besides food, and, lead levels can be checked on a blood test. The thing is too, though, as you were alluding, when long-term problems show up, at that point, lead levels have probably normalized, after months, certainly a year after exposure.
And the treatment ultimately, even if you did come back with a little bit higher than normal lead level, is you just remove the source. And as long as we continue to develop well, the chances of it causing long-term issues are small, especially in these low amounts. Someone's just already gotten out there and said, all right, we're going to remove the source. We're going to do that for you.
Another recent article, Orange County high school start times. There's probably a backstory here. A couple of years ago, law passed that Orange County, by the year 2027, maybe?
That's right, yeah.
2026, 2027, that no high school student could start prior to 8:30, I think was it, right? Yeah. So that was passed.
Right. Mm-hmm.
And then more recently,
They repealed it.
yeah.
So it was a limit originally to say you can't start high school earlier than 8:30. And now the repeal basically is you can, but we're going to leave it up to the counties to decide for themselves in these cases what they're going to do. Teenagers need to sleep in. At the end of the day, teenagers, their clock is just, it's programmed different. They want to go to bed later. They're not just night owls because they want to be, because they're pushing back against us. No, that's what their brains are made to do. They're supposed to stay up later. They're supposed to sleep in. They need just as much sleep as the rest of us, and maybe not even more, considering how much development they're going through. We know that they need to sleep in, and ultimately, I think having high schools start later is a good thing. Unfortunately, there are so many other things that come along with that. What was quoted in the article was that it costs more to have all the transportation for that. There's a lot more buses that need to be bought and bus drivers, things. That's important. It also frequently doesn't fit into the schedules for the people who maybe cart the kids around and pick them up from school. So for parents and the rest of society as well, if we're focusing just on teenagers, I'd love it if they could start school later.
Yeah, it's just complicated, and you don't want to be naive about this as far as the economic impact and extracurricular activities. What does it do for that? It's just, I think the thing as I read this that was just disheartening or frustrating to me was the debate. I mean, the evidence as far as better sleep for teenagers, because I think the average start time now is 7:20 or something.
Yeah, it's before my elementary schoolers.
Yeah.
Yeah. I mean, I leave there and the high schools are already at school.
Yeah. Better sleep, pretty strong evidence for better mental health and better academic performance. And so it felt like the debate about should we do this happened.
Right.
And then as it got close to the cost, and so I don't know. It's frustrating to me that the decision for what had already been decided was best for these kids got sidelined because of it was going to be costly.
Right.
It probably isn't a final number, but an article came out about the number of childhood flu deaths this year, the highest in 15, 16 years.
Yeah, it was 216.
Yep.
And like
above
you
200.
Alluded to, that's likely an understatement. I mean, flu season is just now coming to an end. And of course, as they go through, there will be more. They will find more cause and say, hey, the flu actually was the root of this death. And it's scary. Yeah. It's the highest number since the swine flu.
Yep.
Anyway, it's
2008, 2009. Yeah.
It's too many.
Yeah, no. And it whenever you're talking about numbers, it can be easy to, you don't appreciate the human aspect of it. Thinking of this as it relates to children, and it has to be said as it relates to a vaccine preventable disease. And it time will tell as far as more seasons, but the childhood influenza vaccination rate has declined dramatically over the last 5 years.
It was surprisingly different.
Yeah.
Yeah.
And so for that to have happened in recent years and for us to have the most childhood deaths, you just feel like this has to turn around.
Yeah. This is one of those things where, and we talk about this all the time, is the flu vaccines, I'd love it if you didn't get the flu. Every single time you got the flu vaccine, you didn't get the flu. It's not going to happen. I got the flu vaccine this year. My boys and I, they got it too. And we all got the flu on Christmas Eve. It's going to happen. But we didn't go to the hospital. We didn't have a serious illness. We didn't have pneumonia afterwards. We didn't have influenza related inflammation of the lining of our brain and things. The goal here is to not have serious cases that are potentially detrimental in the long term or potentially even fatal. And that's what the flu vaccine does.
All right. We talked about this last time we were together, that it was likely coming, the banning of fluoridated water in the state, that it's now official, a signed bill going into effect sometime this summer.
July 1st. Yeah.
July 1st. Okay.
Is when, yes, the state says, hey, municipalities can't put fluoride and a couple other compounds as well, but specifically most concerning fluoride in the water any longer.
Any thoughts different than when we talked about last time?
I thought it was interesting a couple episodes ago when you talked to Dr. King about this as well. I thought it was fascinating. And the way my hope is that this is done, but I hope that we will still have access to making the decisions for ourselves if we want to do a fluoride supplement or something like that to make sure our children's teeth are strong. I hope that still is an option for us as we go forward as well. But
yeah, and I think we said last time that, and Dr. King reiterated that this, in some ways, the biggest impact will be on those least able to access dental care. The thing that probably maybe was upsetting to me about when it was signed, there were comments made by the governor that was referring to it as a forced medication. And I feel I get the sentiment behind that, but the reality is we've done this in public health multiple times, whether that's, iodine and salt and the dramatic benefits of that, vitamin D in milk and the dramatic benefits of preventing rickets, enriched flour, and preventing neural tube defects. And so public health has done this incredibly successfully. And so, just words matter, and sort of inflammatory language that makes it feel, I think, more of an intrusion than what some of these historical precedents would say. And then there was something said about that there's a group of people who think they know better for you than you know for yourself. And, one, I'm thinking, yeah, it's a group of people called dentists, but I feel like it just has a potential for further eroding trust. And so in that sense, to me, it's bigger than fluoride and cavities and teeth. It's just this idea that concerns me about society. It needs trust, and it needs to be warranted trust. I get that. And potentially a completely legitimate debate. And so it's not denying the legitimacy of fluoridated water, but just, words matter.
yeah, the first thing that comes to my mind with that is if I have an issue with my car, I want to take it to the mechanic. I want to take it to the person who knows this better than I do. That's the dentists in this case. That's the people who have sat in the lab and done this research and shown, one, it's safe, two, it's effective for protecting. And that's who I want helping me make these decisions ultimately as well. That's why people have specialties in the world.
And then last article we're going to mention that probably maybe a lot of our families wouldn't have caught, but maybe CRISPR technology used to treat a 9-month-old in Philadelphia born with a life-threatening genetic disease.
Yeah, this kiddo had a genetic disease that kept them from being able to process ammonia in their body appropriately. And so ammonia usually comes from proteins in foods. And because this kiddo couldn't do that, the kid was on a very strict low protein diet and had been hospitalized this whole time.
Waiting for a liver transplant.
Right, because that process happens in the liver, and this kid, in this baby's DNA, they just didn't have the right, there was a mutation that kept that from being able to happen. And elevated ammonia levels can be fatal. It's a big deal.
I think it's crazy exciting. And part of it is just looking at this sort of grand meta narrative of pediatrics, and you think pediatricians of generations ago could diagnose scarlet fever and couldn't do a thing about it, and then antibiotics, and pediatricians could diagnose congenital heart defects and couldn't do a thing about it, and then congenital heart surgery. And then you've had these metabolic conditions that, short of things like transplants, universally fatal. And for someone to be able to discover this in bacteria, turn it into a technology that can be given to a child that edits their own genome, it's just crazy.
It's so cool.
And so anyway, just thinking of just as some of these people felt in the past, that kind of being able to experience this happening in real time, that will almost certainly be sort of a new frontier of medicine in the coming years.
I think it probably would be helpful to say, so CRISPR is basically this technology that allows what, like if you allude to there was this gene and this ability that bacteria had to go find viral material that was attacking bacteria and get rid of it. Well, we can now use that to go find broken genes or mutated genes in the body that cause serious problems and go in there, and as kind of like a find, cut, and paste situation, is take out the broken stuff and then now replace it with something that works appropriately.
Yeah, not
works the
just
right way.
slice the gene out, but actually edit it.
Yeah, it's not just turning off anymore. It's now turning it back on in the right way. And they've done this a little bit with kind of bigger things like thalassemia, sickle cell, stuff like that. A lot of research on that we know what the genetic difference is in those things because it's common enough and it gets passed down in the same ways that you know what that is from the get-go. Well, the difference with this kid was they went and found this one thing that this kid had and made it for this child, and were able to put it back and fix things. And they are less in need of a liver transplant now, this kiddo is, and KJ, I think they called, and they were able to loosen the dietary restrictions that this kid had, which is just absolutely incredible that they jump-started this kid's liver and said, here, we'll help you start doing the job.
Yeah, they said there had been some like developmental leaps, some milestones starting to be reached. And
yeah, and I think this kind of goes along with what we were talking about earlier, is the reason that this was able to happen so quickly was because the people who were taking care of this kid in the hospital reached out to a bunch of places and said, hey, we need help. And everyone came together, and a lot of not-for-profits, a lot of universities and things came together to make this happen. And they had the ability to do that because they had the funding to do it and all that kind of stuff as well. And so being able to do these individual things and create these advancements in medicine, that's what all this technology is for. That's what the research and the development is for, is incredible leaps like this.
all right, we've had some questions submitted from families. Thought we'd try to tackle some of these. One of the questions was essentially the likelihood of my child outgrowing asthma. How do you answer that if someone...
It's one of those that you don't know,
right?
Like it'll present itself over time. And we see it relatively often that kids will have symptoms less and less often. And at some point we kind of say, oh, it seems like you've outgrown it because you haven't needed albuterol or inhaled steroid for quite some time. So maybe we've outgrown this. How to answer the likelihood of it, I'm not sure I know.
Yeah, I mean, it's a broad diagnostic bucket. And so it's not like everyone has the exact same entity when you're talking about asthma. What it seems like in response to the question, that those that have less allergic disease are more likely to outgrow it. So the person whose asthma is only presenting during viral illnesses has a higher likelihood of outgrowing it. The person whose symptoms are only at young ages and less so as they get older, which would make sense. Apparently the majority, if you have asthma symptoms at age 8, the majority of those will continue to have asthma into adulthood. Still some will outgrow, but the majority of those will. And then I think there have been a number of studies that have shown that these kids that seem like they outgrow it maybe start to manifest some more subtle symptoms during adulthood, whether just exercise induced or whatever. So probably the way to answer it would be, like you said, you just have to wait and see. But the ones that increase the likelihood would be those that have no evidence of allergic disease, whether that's on testing or just in symptoms. And then people whose wheezing only shows up during viral illnesses.
Yeah, and I always feel like that the people who have more severe illness are all, kind of goes along with this, is they're less likely to outgrow that,
severity.
Unfortunately.
Got a question about sleep regressions and what are they? What should a parent do or don't do during that time? How does it relate to developmental milestones? There's no one ever used the term sleep regression that I remember for the first, 15 years of pediatrics for me, but it's talked about a lot now.
Sure. Yeah.
So trendy, I don't know.
Sleep regression was already in the zeitgeist, if you will, or in the nomenclature when I started going through my training in Arnold Palmer and then coming here. The one that I've heard more, that I'm hearing more and more, is wake windows as well. It's like, what are these? What are these things? And when I've thought about sleep regressions and things, and people are just like, oh, it's the 4-month sleep regression. Oh, it's the 12-month, whichever age it is kids develop in pretty predictable ways. That's why we can monitor milestones and kind of know if a kid's meeting their milestones, if they're a little delayed or if they're kind of getting ahead. And it always seems like a lot of these big changes that are happening come around the same time parents are like, oh, I feel like the sleep's getting a little squirrely and things. And so whether or not it's a biologic thing that our sleep gets squirrely around this age, I just think that there's so much change all the time in babies and in kids that it's going to get rough sometimes. And I just tell parents, I go, look, you gotta have grace with the kids and keep up your routines, keep them up, because it is likely just a little thing they're going through and you're going to get through it as well.
Yeah. One of these, I think, take home ideas about all of parenting is sort of gentle persistence wins. I think so much of our whiffs happen either not being gentle, trying to force something, or not being persistent. We just give up. And so in a very kind of not very specific way, if someone's saying, what should I do and don't do, kind of your point, just gentle persistence about your sleep training. The increased social awareness of a 9 to 10 month old, and we see social anxiety happening around that time. And the idea that in a mini arousal, you're going to have some separation anxiety during sleep makes total sense. I just don't know how many of these sleep regressions have been validated and how consistent they are. But
yeah, and I want to be really clear with, just because they haven't been validated, just because we don't have some biological marker that we can measure, doesn't mean it's not really, really hard.
Yeah.
It is, because anytime sleep is squirrely with a kid, everything's amplified. Everybody's emotions are amplified. It's really hard. And I think the hardest thing is when you see that change is kind of that persistence it's hard to justify it sometimes, because it's just like survival mode kicks in. Everybody needs
and I
sleep.
think maybe what I'm feeling is similar with teething. Even if it is a normal, predictable time, don't let it become license to abandon your routine. And so same thing with, mild illnesses and things like that. Try to just press on, even if it's real. Just don't want it to turn into something more lasting and a problem.
Yeah. Don't let a small wave move the ship necessarily. Yeah.
Last question. Should adults with young children be concerned that we had our measles vaccine so long ago? Question is, do adults need to be vaccinated again if we have a local outbreak? Really two different questions, actually. Got any response to that?
I mean, we know that immunity wanes over time, that we become a little bit higher risk over time. I think the most obvious example of that right now is we're seeing increases rates of whooping cough, of pertussis, and it's usually coming from young adults who haven't necessarily kept up with their tetanus, diphtheria, pertussis boosters. And so we're seeing a lot more cases of that because we know the immunity wanes. Now, specifically with the outbreaks of measles and mumps and rubella recently, there's not any guidance right now that says you should or should not either get tested to see whether or not you're immune or get a repeat vaccine at this point. But just the other day, I had some labs come back on a newborn baby. All moms are tested for their immunity to rubella towards the end of pregnancy, and this mom was non-immune, which to me,
rubella,
to rubella specifically,
Yep.
which to me says the chances are that if we got that MMR vaccine when we were younger, that immunity has waned over time. And so it certainly is something that I've considered, as well as being like, this is what we do. We're in these rooms with little babies who can't be immunized yet. Is it something that we as a society need to consider whether or not it's good for us to bolster our immunity?
I think people from 60s to 90s, so that includes me, we got one.
60s, decades, not
Yes,
age.
not age. Yeah. From born in the 60s to the 90s, you got one, and then it was recommended to start doing two sometime around then. And so currently the recommendation is if you're an adult and you had one, you're good.
Right.
There's no need to go get a second dose. In the event of an outbreak, that could be different,
Sure.
Depending on risk factors and other things. But the answer to the question is you do not need to be concerned. Your vaccine was so long ago and you don't need to do anything different.
Right.
Yeah.
The likelihood at this point of you carrying it around with you is low as far as like illness is concerned.
Yeah, for sure. So definitely enjoy the questions. And we've also received some suggestions for future episodes, topics for future episodes. And so want everybody to know that they can submit those questions or suggested topics to the link in the description. So
Great.
We would love that. Anything else you'd say about anything we talked about?
No, I think I'm just glad people are looking out for us in the labs, in the food labs, everywhere. It's great.
That's great. It takes all of us to care well.
Yeah, truly.
All right. Till next time.
Thank you much.
Yeah.